So when we look at high-risk basal cell carcinoma, so again, this is defined as a BCC that after treatment has a high risk of recurrence. And the risk factors for that include the location as well as the size of the tumor, similar to how we defined low-risk BCC. Here, the location could be anywhere on the head and neck, on the hands, the feet, the pretibial skin, or the anogenital skin, or tumors that are greater than 2 centimeters on the trunk and extremities are also considered high risk for recurrence. Additionally, a high-risk BCC can be a tumor that demonstrates aggressive features under the microscope, such as perineural invasion, for example. And other risk factors that would make a tumor more likely to recur after treatment include a lesion that is already recurrent. We want to be a little more aggressive with how we manage it. A lesion that is very poorly defined to the naked eye, so the tumor borders are poorly defined, or if this is a skin cancer that is arising in a site of prior radiation, or if the patient is immunocompromised. So how do we manage high-risk basal cell carcinoma? We usually prefer surgical techniques that would allow for complete peripheral and deep margin assessment. Possibly the most well-known method for this is Mohs micrographic surgery or Mohs surgery. This is a technique that is performed by a dermatologist who is trained in Mohs technique. It offers very high precision with tissue sparing. So it's an excellent option for skin cancers such as BCCs on the head and neck. Additionally, it is associated with very low recurrence rates for primary and for recurrent BCCs. An alternative, so Mohs surgery, the way that this is performed is the patient is evaluated by the Mohs surgeon, the site is marked and numbed, similar to how we do when we perform the biopsy, and the tumor is removed in thin slices, so very small layers that are processed while the patient is waiting in the room. The Mohs surgeon, after the slides have been processed, looks at them under the microscope to determine whether or not more layers need to be removed or whether the margins are clear. In which case, once the margins are clear, the site is closed, usually all within the same visit. An alternative to Mohs surgery is to perform a staged excision where the tumor and the margins are removed and submitted to the path for processing. But there's often a delay between the excision and the closure because there's a delay between, again, the removal of the tumor and the margins and the processing. So oftentimes the closure of the site will happen after the removal of the tumor. If a procedure such as Mohs surgery or staged excision to allow for complete margin assessment is not available, another option is to perform a standard excision with wider excision margins, that is margins of normal skin around the tumor. And lastly, for high-risk basal cell carcinomas in patients who are non-surgical candidates, radiation therapy can be considered, and that's a discussion to have at this point with a radiation oncologist.